Welcome to this professional training course on the emergency triage system. This video is intended for EMS, paramedics, and first responders, focusing on the START algorithm, clinical logic, and scene management. Please ensure this material is reviewed and approved by your local medical director before any implementation in the field. Triage finds its roots in the French word trier, meaning to sort. Historically pioneered by Dominique Jean Leray in 1792, the modern approach in mass casualty incidents requires a utilitarian paradigm shift, doing the greatest good for the greatest number of people using limited resources. Understanding the difference between field and clinical protocols is vital. While the START and JumpStart algorithms prioritize physical survivability in resource-limited field environments, the Emergency Severity Index used in hospital settings balances patient urgency with available diagnostic and procedural resources. Stage 1 of the START method is the global sort. By instructing all patients who can walk to move to a safe area, responders can immediately clear 40 to 60% of victims from the hot zone, allowing focus on those who are non-ambulatory. For the remaining patients, we apply the 30-2 can-do RPM process. This evaluates respiration, perfusion, and mental status in that specific order. If a patient fails any check, the assessment stops, they are tagged immediate, and the officer moves on, keeping assessments under 1 minute. In the first RPM check, we evaluate respiration. If the rate exceeds 30 breaths per minute, the patient is tagged red. If the patient is apneic, a simple manual airway maneuver is permitted. If they remain apneic after this attempt, they are tagged black. Step 2 evaluates perfusion. If the radial pulse is absent or capillary refill exceeds 2 seconds, the patient is tagged immediate. Note that in cold environments, capillary refill may be unreliable, so prioritize the radial pulse check. Control major hemorrhaging immediately if identified. The final RPM check is mental status. Issue a simple command like "squeeze my hand." If the patient cannot comply, they are tagged immediate. If they successfully follow the command and have passed the previous checks, they are tagged delayed or yellow. Defining triage categories is essential. Immediate or red tags are for life-threatening but salvageable patients. Delayed or yellow tags are for patients with serious but stable injuries whose definitive treatment can tolerate a delay without worsening their outcome. Minor or green tags are for the walking wounded who require secondary evaluation later. Expectant or black tags are for the deceased or those with injuries where survival is unlikely, allowing resources to be focused on those who can be saved. Triage is dynamic. Secondary triage continues as patients move toward definitive care. Responders must remain vigilant for condition changes that require retagging, such as a patient decompensating from green to red or stabilizing from red to yellow. Finally, accurate documentation ensures seamless handoffs to transport units and hospitals. Collected data, including assessment times, triage categories, and physiological findings, are crucial for after-action reviews, which help refine future protocols and improve mass casualty response outcomes.